So hello my friends, today we are going to talk about interpretation of the coagulation profile. So basically we'll be looking at what is a coagulation profile and what are the parameters that we have to assess in coagulation profile. And then we will be discussing the diagnostic algorithm. So it's a diagnostic algorithm for pediatric bleeding and clotting disorders. So there are so many bleeding disorders in kids and a few clotting disorders as well. So how do we follow a proper diagnostic algorithm to diagnose these conditions? So without further ado, let's start today's topic. So to begin with, the main points of today's lecture is number one, how do we interpret the coagulation profile? So in other words, we will be talking about the particular tests that are done in the coagulation profile and what is the meaning when those values are reached. The other point that will be discussing today is why we need the coagulation profile. I mean, what are the conditions in which we would be ordering a coagulation profile? Then we would also be talking about what are the components of this coagulation profile. Like for example, we would be talking about the prothrombin time, the activated partial thromboplastin time, fibrinogen time, APT ratio, so on and so forth. And then we will be talking about some methods by which we can easily remember the coagulation cascades. So these are the four main points that we are going to discuss in today's lecture. So let me start with the last one, that how can we easily remember the coagulation cascade? Now, if you look at this diagram, I mean, if you recall your memory, when was the last time you understood and remembered the coagulation cascade? And you can see how it looks like. So even if you had understood at that point in time when you were a medical student, I am pretty much sure that by this time you have forgotten actually what is meant by the extrinsic pathway, what is meant by the intrinsic pathway, what is a common pathway, and how this whole thing works. So it looks very, very complex because there are so many factors from 1 to 13, and then the way which one comes first, which one comes after that, looks a bit complex. So let me make your life very, very, very easy. I will give you a very simple method by which you can remember this coagulation cascade for the rest of your life. So before I go into that pathway, just remember two things. The coagulation pathway consists of two things: an extrinsic pathway and an intrinsic pathway. Now, what is an extrinsic pathway? Extrinsic pathway is that part of the coagulation profile which is actually activated when you have got an injury or when you get a wound. So for example, if you get injured or if you got a cut or a laceration on your finger or scalp or anywhere, and then the wound starts bleeding, and after sometimes the bleeding stops, what is happening basically is that your extrinsic pathway has been activated. So extrinsic pathway is activated by wounds and injuries. Intrinsic pathway, on the other hand, intrinsic means from inside. So it's usually activated when there is some endothelial injury. For example, some form of vasculitis or something from within the blood vessels. And there are different types of disorders in which this can be actually activated. So intrinsic pathway is activated from inside the blood vessels, endothelial injury, while the extrinsic pathway is activated by the tissue injury. That's more common, like injuries and wounds. So these are the two things. At some point they form together, they form the common pathway, and from there ultimately what you see is a stabilized clot. So this is the a very general physiology of the coagulation. Now, how do these pathways work? Now let me tell you about that. So I will draw a diagram. So let me show you how this thing works. So if you take a piece of paper and if you draw an X in the center, remember an X is the Roman numeral for the number 10. So X, remember there are factors from 1 to 13 and 10 is in the center. So on a piece of paper, draw this X in the center. So this X is the center. Okay. From this, what you can do is you can make two arrows. So one arrow goes diagonally to the left side, the other arrow goes diagonally to the right side, and then one arrow goes down. So you are actually making a sort of a triangle out of that. One is going in the left upper direction, the other is going in the right upper direction, the third is going down. Now from X, the downward pathway is the common pathway, the left upward pathway is the extrinsic pathway, and the right upper one is the intrinsic pathway. So let's start with the common pathway. So from 10, remember because I told you there are factor 1 to 13. So remember, from 10 you have to go back, but in form of the factors. So let's say from 10 you divide 10 by 2, so take halves of each. So half of 10 is 5, so write 5 below what? Below 10. Then take the half of 5. Half of 5 is what? 2.5. So we will convert into a full round figure, and that would be 2. So write 2 beneath that, and then half 2, like divide 2, and that would be 1. So 10, 5, 2 and 1. So if you go back in this order, 10, 5, 2, 1, this is your common pathway. So remember, from 10, half it, divided by 2, 5 divided by 2, again that would, what would happen? That will give you 2.5. Take it as a round figure 2, and then divide it again by 2, that would give you 1. So 10, 5, 2, 1 are your common pathway. On the left upper side is your extrinsic pathway. Now remember, extrinsic pathway is just factor 7. What? Factor 7. So factor 7 when exposed to tissue, which is your factor 3. Remember this tissue, when something is exposed to tissue, that is factor 3. So 7 and 3 are your extrinsic pathway. So extrinsic pathway is what? Factor 7, and tissue with it is 3. Now on the right side is your intrinsic pathway. So intrinsic pathway, go backwards from 12. 12, then after 12, if you go backward, would be 11. Then after 11 would be 10, but we already have got 10 written here, so just omit 10. So 12, then you go backward 11, then you go backward, obviously you omitted 10, then you've got 9, then you've got 8. After 8 you've got 7, but you don't need to write 7 because 7 is already as a part of the extrinsic pathway. Okay, 6 is not there. Okay, so 6 is basically is not included in that. 5 we already got. 4, forget about that. Okay, 3 we already got in the extrinsic pathway. 2 and 1 are down in the common pathway. So this is how you would remember. So the common pathway, remember 10 is in the center, so 10 divided by 2, 5 divided by 2, 2.5 equal to 2, then divided by 2, 1. So 10, 5, 2, 1 are your common pathways. Your extrinsic pathway is only factor 7. With that, the tissue is actually factor 3. And if you count back from 12, 12, 11, 10 is already out, 9 and 8. These are your intrinsic pathway on the right side. Now you will say, where is 13? 13 is the last most. Okay, some people say 13 is not a good number. Okay, it is usually associated with haunting memories or something scary. Anyhow, so this 13 comes at the last. This 13 is the clot stabilization factor. This is at the very end of the common pathway. Okay, so this is very end. Just take it as the very last part of the coagulation cascade. So this is how you should remember the coagulation profile. I hope with this simple method, if you do it once on a piece of paper, probably you would remember it for the rest of your life. Okay, so let's move on. Now coming down to when we need the coagulation profile, or in other words, when you would be ordering a coagulation profile. I've seen many doctors, they just like order coagulation profile when they are doing blood tests. No, you need to know why you're ordering coagulation profile, because you have to interpret that. So you only need coagulation profile when you actually need it, when you are actually trying to get some information of it. You don't simply do it because you're doing blood tests. Okay, you say, when I'm taking bloods, let's do the coagulation profile as well. No, you do the coagulation profile when there is a history of either repeated mucosal bleeding, so somebody bleeding from, let's say, from the gums, from the mouth, from the nose, maybe repeated hematuria. So from mucosal bleeding again and again, if there is a history, you would be probably ordering a coagulation profile along with a full blood count, because in all the bleeding disorders we also have to look at the platelet count, which would come from the full blood count. So if there's a history of repeated mucosal bleeding, if somebody has got prolonged post-operative bleeding, that's another indication for ordering a coagulation profile. If somebody has got prolonged wound bleeding or repeated wound bleeding, so if somebody has got a wound and that should stop in some time, so if it is not stopping bleeding, or if it stops and then starts recurring, then that would be another indication to look at the coagulation profile. If somebody has got easy bruising and has developed purpuric rashes, they also need a coagulation profile. If somebody has got internal bleeds, like bleeds into the joints, into the closed cavities, that's also an indication to order coagulation profile, especially if they are on blood thinning agents. Major pediatric trauma where there is catastrophic bleeding, you definitely need coagulation profile because you have to look at certain parameters and keep them under control. If there is a severe infection like a sepsis or macrophage activation syndrome, which is leading to disseminated intravascular coagulation, which is a very life-threatening condition, you need a coagulation profile. Coagulation profile is also needed pre-operatively because these patients would be operated. There will be like sort of a surgical cuts, and they want to know if the child would bleed excessively or not, so they want to look at the coagulation profile. So that's always ordered pre-operatively. If somebody is having certain types of clotting disorders, they would the coagulation profile needs to be done in order to see what's going wrong. And if somebody's got a history of superficial or deep vein thrombosis, they also need a coagulation profile. So you can see the list is quite big one, but these are the indications in which you would require a coagulation profile. So you do not order coagulation profile blindly. You need a proper reason to order coagulation profile, and these are some of the conditions in which you would be ordering coagulation profile. Now, moving on to what are the components of coagulation profiles and how do we collect blood. So you might have seen the light sky blue bottles. So usually the large ones, the adult ones, have got the light sky blue color. The pediatric ones have got a dark blue color. But remember, they are separate from the purple ones, which are for the full blood count. So these are special bottles and they have to be filled up to a certain mark. So remember, you have to always fill up these bottles properly. Now, to fill up these bottles properly, if you are using a vacutainer, like in adults you use a vacutainer, then because vacutainer has got a needle, remember when you are taking different bottles for blood tests, remember you always take the sky blue first. So if you are using the vacutainer, then the order is very important. The sky blue bottle goes first. Why? Because you don't want some contaminants from the other bottle to interfere with the anticoagulants in this sky blue bottle, which would give you wrong results. So whenever you are taking bloods through the vacutainers, for example in older children or in adults, you always use the sky or the coagulation bottle first, followed by the gold top or the red top second, and the full blood count bottle or the purple bottle is taken at the last. But let's say if you are taking in a very small child where the blood is coming, you are taking the blood by free flow, then the order doesn't matter because obviously nothing is contaminated. You just have to hold the bottle beneath the cannula. So in that particular case, the order doesn't matter. But if you're using a vacutainer, then the coagulation profile bottle should be filled first. This is very important. Now, what are the components of coagulation profile? Number one, PT, which stands for prothrombin time, which looks at your extrinsic pathway. PT, prothrombin time, always look at the extrinsic pathway. APTT, which stands for activated partial thromboplastin time, but in most of the cases the labs, they just use the word PTT. It's actually APTT. That is for looking at the intrinsic pathway. APTT, activated partial thromboplastin time. But then we've got the INR, which is the international normalized ratio, which is the PT of the patient divided by the standardized prothrombin time. The same goes for APTT, where it is known as the APT ratio, which is the ratio of the APTT of the patient followed by standard APTT, which is a normal APTT. And then we've got the fibrinogen level. Fibrinogen is basically a acute phase reactant as well, and their values are also taken. So the normal PT, again, values depends on the labs, but more or less the values are between 11 to 13.5 seconds. For APTT is 30 to 40 seconds. For INR, it should be somewhere between 0.8 to 1.2. It's a ratio, so it hasn't got any units. The APT ratio, activated partial thromboplastin ratio, would be somewhere between 1.5 and 2.5. And then we've got the fibrinogen levels, whose levels should be between 200 to 400 milligram per deciliter. So these are the normal values for the different components of a coagulation profile. Now let's talk about the diagnostic algorithm and its interpretation. So now we'll be looking at how do we diagnose different types of disorders based on interpretation of this coagulation profile. So here on the screen you can see an algorithm. So let's say you have done a coagulation profile and you have got the results in front of you. And as I told you earlier, that it consists of 5 things. You have got the PT, prothrombin time, that is your extrinsic pathway. You've got the APTT, that is activated partial thromboplastin, which is your intrinsic pathway. Then you've got the INR, you have got the APT ratio, and you've got the fibrinogen levels. So you would be looking at all these things. Let's say only the PT is prolonged, everything else is fine, just the PT values are raised. PT, I told you, looks at the extrinsic pathway. So what is your extrinsic pathway? Your extrinsic pathway, earlier I told you, is factor 7. So if there is let's say congenital deficiency of factor 7, then your PT would be prolonged, everything else would be fine. PT is also prolonged if somebody has got vitamin K deficiency. So vitamin K deficiency can occur in neonates if they have not been given vitamin K injections. In older people also sometimes vitamin K deficiency can develop because of various gut problems. It can also occur in liver disease, and PT can be isolatedly prolonged if somebody is on warfarin therapy as an anticoagulant therapy. So they would be having isolated PT prolongation with the rest of the factors normal. Though vitamin K and liver disease, because they affect at different points in the extrinsic and intrinsic pathway, the other factors can also be elevated. But in mild forms of liver disease, mild forms of vitamin K deficiency, you might sometimes see that there's only a PT prolongation with the rest of the parameters being normal. Now if you see the PT is normal, it's just the APTT which is prolonged, rest of the factors are fine. And I told you APTT or intrinsic pathway is your factor 12, go backwards 11, 9 and 8, and with 8 there is another factor which is part of the factor which is known as von Willebrand factor. So a deficiency of either the factor 12, factor 11, factor 9, factor 8 or von Willebrand deficiency can give you an isolated prolonged APTT time. Now remember, factor 8 deficiency is your hemophilia A, factor 9 is your hemophilia B, factor 11 deficiency is your hemophilia C. So remember, this hemophilia A, B and C is the most severe, 9 is slightly less, 11 is even less, and von Willebrand deficiency is a different domain. So these factor deficiency can give rise to isolated APTT deficiency. Factor 12 is quite peculiar in this because factor 12 patients do not have any symptoms. All their life they are absolutely fine. But what would you happen is that whenever you do their coagulation profile, the APTT would be sky high, but they never develop any bleeding problem. So this is quite peculiar. So factor 12 kids are very well, they never develop any deficiency, any problem factor 12 deficiency, but they always have got a sky high APTT level. So let's say if the APTT level is prolonged, because there are so many factors, we do the mixing studies. So what are mixing studies? You take the patient blood and you take the normal plasma and the patient blood, you mix them together. So let's say if there are any factor deficiency and you put normal plasma into that, what would happen? The deficiency, the factor deficiency would be corrected. So we see if the APTT is corrected after mixing normal plasma into the patient plasma, we call them mixing studies. So let's say if after mixing studies the APTT corrects, it means you have got some factor deficiency. It would be factor 8, 9, 11, 12, whatever factor deficiency is there. Then we have to do further factor assays to see which factor is actually deficient. But let's say if it does not correct after mixing, it means what is happening? The factors is not a problem, but rather the patient has got possible inhibitors. There are certain types of inhibitors, anti-lupus anticoagulants, which probably is suppressing these factors. We call them the inhibitors. So if it does not correct after mixing, then the patient has got what? Inhibitors, not the factor deficiency, but the inhibitors. Now what if both PT and APTT are prolonged? If both they are prolonged, then probably you are looking at the common pathway. So factor 10 deficiency, factor 5 deficiency, factor 2 deficiency, they can happen. So in that particular case, you also have to do the factor assays to see if the factor 10, 5 or 2, which one of them is deficient. Now in these factor assays, let's say if you find that the factor 5 and 7 is low, but factor 8 is normal, you are probably looking at the liver disease, advanced liver disease. If the factor 5 is normal, factor 8 is normal, but only the factor 7 is low, you are probably looking at vitamin K deficiency. And if you've got all the factors low, you're probably looking at disseminated intravascular coagulation, or sometimes dilutional coagulopathy, in which there's too much dilution and it's consuming the coagulation factors. If you've got the increased INR, increased, like, where the PT is raised, and it is like, you take the standard PT and you take out that ratio. If it is more than 1.2, then probably this can happen because of anticoagulant treatment like warfarin therapy. It can also occur because of vitamin K deficiency, liver disease, and disseminated intravascular coagulation. We sometimes take it in pediatric practice. Kids, adolescents who have done paracetamol poisoning, when suffering from paracetamol toxicity, might develop acute liver failure. In that particular case, you will see that the PT is quite prolonged with an increased INR. Usually PTs and even the ALT, the liver enzymes, would be running in thousands. Fibrinogen is actually an acute phase reactant. So if fibrinogen is raised, it simply means that there is an infection or inflammation somewhere in the body. But if it is decreased, it might mean that there's a qualitative problem with fibrinogen, which we call as dysfibrinogenemia, or there might be congenital deficiency of fibrinogen, which is afibrinogenemia. And if there is an increased APT ratio, then it means that there is either the patient is on heparin therapy, or there are inhibitors in his blood, or there might be having lupus anticoagulant in his blood. So these are some of the interpretations of either a prolonged PT, a prolonged APTT, or a combined prolonged PT APTT, or problems with INR APT ratio, or with fibrinogen. So that is the diagnostic algorithm. So if you have got a screenshot of this thing in front of you, and you have got the coagulation profile results of the patient, and you just follow this, you would probably reach the diagnosis, or at least even if you're not reaching the diagnosis, you know at least what is the next best step in the further diagnosis of this patient. So this is a very simplified diagnostic algorithm to further look into the values of the parameters of coagulation profile. Now remember, if the coagulation profile is normal, let's say everything comes out to be normal, but you've got a very high suspicion based on clinical presentation because the child has got delayed bleeding or something, you think something is going on, but the coagulation profile is absolutely normal, then think of some other things. Number one, functional platelet disorders can also present with like mucosal bleeding, repeated mucosal bleeding. Everything else is fine, including the platelet count. So in that particular case, you might have to do functional we call the platelet assays or platelet aggregation studies, because you are thinking of either the Glanzmann thromboasthenia or Burnout-Soulier syndrome, which are platelet aggregation disorders. We also call them functional platelet disorders. You might also have to do fibrinolysis studies, which actually includes testing for factor 13, because factor 13 deficiency would present with delayed wound bleeding excuse me, and everything else, the coagulation profile is normal. So you have to test for either factor 13, or sometimes alpha-2 antiplasmin or tissue plasminogen activator deficiencies can also give you bleeding problems, but everything else with coagulation profile is normal. Or some of the mild factor deficiency, especially the mild deficiency of factor 8 and 9, the coagulation profile would be normal, but the child might be presenting with repeated bleeding diathesis. So these are the few things which you have to keep in mind if the coagulation profile is normal, but you are still thinking that there might be an issue. So remember, in that particular case, you have to think about this algorithm, think about functional platelet disorder, think about factor 13 or TPA or alpha-2 antiplasmin deficiency or mild factor deficiency. So this is the way you need to look into coagulation profile interpretation. And if you are dealing with a child who has got probably a bleeding disorder, and you have ordered these tests and the results are in front of you, you can use these algorithms to further look into what are the best next steps, or how you can narrow down your differentials. So I hope this lecture makes this coagulation cascade and interpretation of coagulation profile easy for you, so the next time you see a patient and a coagulation profile is in front of you, it's easy for you to diagnose these problems. So I hope you have understood this thing. Still, if you've got any questions, you can ask me in the comments section, and have a very good day. Take care and bye-bye.